So while Dr. Pinkney sets up, I just want to thank everybody for coming online this evening. And we're in for a treat. We have Dr. Pinkney back with us again. After last year, we were all very stimulated to go read some more about syphilis. And we're back to hear a lot more about syphilis, an update, if you may. And we will also be hearing about the maternal RSV vaccines. So sit back, relax, and enjoy, everyone.
Hi, are you guys able to see my screen?
Yes, it is. Oh.
Okay, all right, thank you. Yes, okay. All right, so we are back with updates in syphilis this year, but we will be taking or review of last year as well. So firstly, I have no disclosures, but just as last year, syphilis cases continue to be on the rise. And this is every single type of syphilis, right? Which is known as the great imitator. So syphilis, we have the primary stage, secondary, latent, tertiary. Neurosyphilis is on the rise, as well as ocular and otic syphilis and congenital syphilis. If we look at the US statistics, we actually can see in the early 1940s, in this graph, we have time on the x-axis and the number of cases per 100,000 population on the y-axis. You can see that syphilis was extremely high in the 1940s, around the time of the World Wars, going up to over 400 cases per 100,000 in the population. But around 2006, thereabout, it was at a all-time low. And in fact, we were, as a global community, very, very optimistic that we were going to end syphilis. There were many World Health Organization posters and calls for the elimination of syphilis. However, after that time, we see that there was actually a rise that was starting to happen after 2006, where it was going up every year. In fact, by 2015, there had been a 19% increase in syphilis in most of the US states. And that has only continued to get worse. If we compare syphilis to other sexually transmitted infections, such as chlamydia and gonorrhea, that initially had an increase and then started to decline, syphilis, all stages, including congenital syphilis, has continued to trend upwards. These are cases ranging from 2018 to 2022 in the United States. And you can see that there is a 78.9% increase in all stages of syphilis and 183% increase in congenital syphilis from 2018. Groups that deserve special attention, as we just mentioned, congenital syphilis, if we were to look even further back to 2010, there's been an over 700% increase. The MSM, or men who have sex with men population, has also seen an over 700% increase since the year 1999. And similarly, persons with human immunodeficiency virus have seen a 40 to 50% increase in co-infection of syphilis and HIV. And if we were to look at other groups, women are also experiencing an increase overall. For instance, in 2019, in 2023, Houston reported that there was a 128% increase among their female population starting from 2019. And within the US, there are significant racial and ethnic disparities, with the American Indian and Alaska Native population experiencing the sharpest rise in 2021, followed thereafter by the Black American and African American community, with the Asian population having the lowest incidence of primary and secondary syphilis. In the Caribbean, there is not that as much data as there is in the US, but I found that in 2019 to 2020, there's a combined report syphilis seropositivity of greater than 1% in Bahamas, Cuba, Haiti, Jamaica, Panama, and St. Lucia. And in Dominica, they also reported a 1.4% seroprevalence. If you look at the seropositivity among men who have sex with men, as I said, this is a particularly vulnerable group with a high incidence in the US. Like the US, we see a very high positivity rate. In the Bahamas, for instance, 35% among their MSM community. In Trinidad and Tobago, it's 16% among their MSM community. This rise or resurgence of syphilis has led to penicillin stockouts that has started from about April of 2017. A global survey of 95 countries had shown that around 41% of them had reported a shortage of benzathine penicillin G, which is the treatment of choice or the gold standard for treating syphilis. And because it is in such shortage, the price of syphilis treatment with penicillin has also gone up significantly, with GoodRx quoting prices between 3,000 to 5,000 US dollars for 3 doses of the 2.4 million units. It was expected that this resolution would happen by October of this year, but that is yet to be seen. And this is just a picture of, the community, the AIDS Health Foundation, sorry, actually protesting about the shortage. So with that, this antibiotic shortage paired with the already increasing cases that we're seeing, we can expect that the syphilis cases may just continue to go up. So what is driving this resurgence? There's a saying, sex, drugs, and rock and roll, but I would change it to sex, drugs, and perhaps Tinder and other social media platforms like Grindr. So currently, the current cluster that is involved in the pandemic is the azithromycin-resistant strain. And there's been some theoretical postulations that there's been an increase in condomless sex after the release of pre-exposure prophylaxis or PrEP. And that was partly supported by the Australian PrEP-X study, which found significant increase in rates of syphilis, gonorrhea, and chlamydia in the individuals who were receiving PrEP compared to those who were not. There have also been significant budget cuts in prevention programs for syphilis. As we mentioned, there's social media platforms that are perpetuating promiscuity and high-risk sexual encounters. And then there's a large intersection between drug use and syphilis among the heterosexual male and female population, particularly in California. There's they call it chemsex, where there's a use of methamphetamine to enhance the sexual experience. And then there's obviously perpetuation of condomless sex and these adjoining STIs. So the World Health Organization, at their 69th World Health Assembly in 2016, had actually aimed to decrease syphilis incidence by 90% by the year 2030, and to decrease the incidence of congenital syphilis to less than 50 cases per 100,000 live births by 2030. That's just 6 years away. And as we can see, we are not on that trajectory if we continue to implement the same things we've been implementing these past few years. A drastic change is needed. So with that, we will go over our natural history of syphilis, the updates in the case definitions, including a few words on neurosyphilis, ocular syphilis, and congenital syphilis. We will also have some updates in diagnostic testing algorithms and diagnostic dilemmas, updates in screening recommendations, and updates in syphilis prevention, which is very hot topic nowadays, doxycycline post-exposure prophylaxis for syphilis prevention. And then we will do our take-home points. So for syphilis is a sexually transmitted disease caused by the spirochete bacterium Treponema pallidum, subspecies pallidum. It's transmitted from person to person through direct contact with a syphilitic chancre. And many chancres are unrecognized, so transmission may occur from persons who are unaware of their infection, particularly if the chancre is on the cervix in the female genitalia tract. It's somewhere that is not able to be seen externally, and so that is an easy way to promote transmission. And syphilis can also be transmitted from mother to child. Syphilis has many disease manifestations. Traditionally, it is taught as a continuum after infection, but now we're learning more and more that people can go back and forth between stages. It's not a straight linear pathway. It can definitely, you can be asymptomatic and then be in late stages if you're not treated. So in terms of the continuum, from the time of exposure to the syphilis bacteria, persons usually get a primary infection followed by secondary early latent, which can be divided into early non-primary or non-secondary syphilis. That's the new nomenclature for early latent. And then late latent, which is now categorized as syphilis of unknown duration or late syphilis. Neurosyphilis, ocular syphilis, and otic syphilis can occur in any of these stages. Traditionally, we used to kind of think of neurosyphilis as a tertiary manifestation, but now more and more we're recognizing that it can occur even after the initial exposure in the primary stages. So with primary syphilis, it usually occurs 10 to 90 days after exposure, and it's characterized by a painless ulcer at the site of infection, called a chancre. And the chancre can occur on the tongue, as we see in this picture here. It can occur on the finger, on the glans penis, and in areas not seen, such as the cervix or the anus. And this stage is infectious. So once we have a visible chancre, you should be, not only should the patient be treated, but their partner should be treated as well. At the top of the page here, we also have some a representation of finger condoms that can be used to prevent like a finger chancre. For the secondary syphilis, this usually occurs 4 to 10 weeks after the appearance of the chancre. It can be characterized by either a localized rash or a diffuse mucocutaneous rash or lesion. Other signs of secondary syphilis include mucus patches, which people don't normally think of. They might think these mucus patches are, for instance, aphthous ulcers related to their toothbrush, but just be very vigilant that this can be a manifestation of secondary syphilis, as can alopecia. People often think of alopecia with, for instance, thyroid disease, but secondary syphilis is something that should also be on your list of differentials in this high incidence time. This stage is also infectious and it can resolve without treatment. Here are some graphical representations here of a syphilitic lesion on the anterior shin. Here is the classic rash involving the palms and soles, and here's a serpiginous lesion on the sole of an infant's foot. So to understand the latent phase of syphilis, or what that means, we must first understand the diagnostic testing for syphilis. So overall, I would say that the diagnosis of syphilis would be so much easier if we were able to grow it on some form of culture like most other bacteria. But it is very difficult to culture. I think they're using testicles of rabbits that it uses to grow. So we have to rely on other methods. And so in terms of the methods we rely on, we have direct methods and we have indirect methods. For the direct methods, that's where we actually are able to visualize the bacteria like as a whole, and that includes dark field microscopy of lesion exudates. It also includes electron microscopy. And there are also molecular diagnostics where we can actually detect the DNA or RNA by PCR for the syphilitic lesions. And that's used mainly in the diagnosis of congenital syphilis or for research purposes. The type of sequencing is usually 16S sequencing, 16S RNA sequencing for syphilis. The other methods that we are more familiar with that are not used in research but are used clinically in the day-to-day is the indirect or serological test. So the serological or indirect test can be divided into treponemal and non-treponemal. For the treponemal, these are detecting antibodies directly against the syphilis bacteria or Treponema pallidum. So it's detecting IgM and IgG antibodies to the bacteria, whereas your non-treponemal serological tests are detecting antibodies to synthetic cardiolipin. So here on our seesaw, we see we're very familiar with the treponemal assays. The ones that I know we used to use in the lab are the fluorescent treponemal antibody or FTA-ABS. And then they also use the treponema pallidum particle agglutination, TPPA. But I believe the last year, there was also mentioned that UE was getting the enzyme immunoassay. Not sure if that has been there, but that's the enzyme immunoassay is what we use in the US. And then in terms of the non-treponemal tests, these are the ones that gives us a titer of how high or how much the burden of syphilis is. So we have the VDRL or Venereal Disease Research Lab, and you have the rapid plasma reagent. And if you guys have been to the micro lab, you've seen these little cards for the VDRL where we look for the flocculations, and then we can tell if it's a titer of 1 in 10 to 24, 1 in 64, based on how far the flocculations go. In terms of the timing of serological responses in syphilitic infections, here on this graph, we have the time on the x-axis in weeks to years, and on the y-axis, we have the percentage of patients who test positive. And so first we're going to follow the IgM because that is the first antibody that's usually made after exposure to infection. So we can see within 1 to 2 weeks, we get an initial rise of the IgM antibody, which goes away after around a year. And then around 2 to 4 weeks after the appearance of the IgM, we have the appearance of the IgG, which is in the green line. And that IgG is what is present for life. And so when we talk about the treponemal antibodies, if we go back here, you can see that if we're looking for IgM and IgG to the treponema pallidum, these will be persistently positive because they go on for the lifetime immunity. Whereas if we look at our VDRL and RPR, they become present around 2 to 4 weeks afterwards. If you're treated, the VDRL and RPR should actually become negative or decrease by at least twofold. If you're untreated, there is a fall in the titer, but it usually does not go down to an undetectable level. So which test is best if we were to compare the TPPA to the FTA, for instance, and then our VDRL and RPR? I would say overall, if we're looking at primary syphilis or TPPA test and or enzyme immunoassay test is 94% sensitive, so they have a very high sensitivity rate. So if you're testing someone, for instance, that has a chancre, these should be able to pick it up. It should be positive. Although we can see that because they're testing the IgM, you still have like a 1 to 2 week window where that could initially be negative. Similarly, for early latent, their TPPA and your FTA is 100% sensitive compared to your VDRL and RPR, which is not that bad. It's 96, 98. But you can see that the VDRL and RPR are less sensitive for primary syphilis than the treponema test. So the EIA, the TPPA, the FTA are more sensitive than the non-treponema test for primary. In terms of specificity, the TPPA test is 100% specific. The VDRL and RPR are not that far behind at 98%, so they're good. And then late latent is really the one that's very hard because the sensitivity is not that great. The ELISA or enzyme immunoassay has the best sensitivity for late latent at 98%. But VDRL and RPR are at 71 and 73% respectively. So in terms of updates in diagnostic testing algorithms and diagnostic dilemmas, so traditional testing, we used to screen or start off with the non-treponema test, so that's the VDRL or RPR. And then if that was positive, then we would go on to test the treponema test with either the FTA or in the US, the enzyme immunoassay. However, as we just saw, that could miss some early cases, particularly primary syphilis, and it could also miss some latent cases. This method was also time consuming. You needed a lot more manpower to read those VDRL cards and count up the populations to see what the titer was. And so in 2004, the US switched over to starting with a treponema test that could be run in batches. You could run the enzyme immunoassays in batches. And so that was much less manpower, much less time. And I believe last year on this talk, I was told that UE was moving to that algorithm as well. So with that, you start with the treponema test. If it's positive, then you go on to do a quantitative non-treponema test with either an RPR or a VDRL. And then if that's positive, we can say that the person has syphilis. Whether this syphilis is past or present depends on what the patient is presenting with. Have they been treated in the past? Because as I said, the immunoassay test or the treponema test, the IgG, is lifelong positive. So it could be someone that was treated in the past, and you have to ask that question. And then what is their current infection risk? If it's negative, then you can go on to do a TPPA. If that is negative and the person has a risk factor for syphilis, then it's recommended that you repeat the RPR or the non-treponema test in several weeks. In the other arm, if the screening tests for the enzyme immunoassay, meaning the IgM or the IgG to the treponema bacterium is negative, then they recommend that if you have clinical signs that pointing to primary syphilis, that you treat, but if not, you just treat it as a negative test. So traditionally, we would think of latent syphilis as a person who is asymptomatic, but they have a positive treponemal antibody test and a negative non-treponemal test, a negative RPR or VDRL. And then it's confirmed positive with another treponemal test, like a TPPA. Then we'd say that the person has latent syphilis. Now, latent syphilis is divided into early, which is less than a year, or late, which is greater than a year. And in 2017, they changed the nomenclature from latent to early non-primary, non-secondary syphilis, mainly for emphasis that latent stages can still be infectious. So there was this assumption that because you are labeled latent, you can't transmit the infection to someone else and partners shouldn't be treated. But now with removing latent from the nomenclature and calling it early non-primary, non-secondary, even though that's a mouthful, it's kind of emphasizing that this is not something that is non-infectious, but it's still important enough to consider infecting others and transmission to others, and their partners should be treated. It also highlights that clinical manifestations, example, neurosyphilis, ocular syphilis, and otic syphilis, may occur during any of these stages. Similarly, in 2017, the nomenclature for late syphilis or unknown or late latent was changed to late syphilis or unknown to once again emphasize that this stage includes cases with an unknown duration of infection, and you should prioritize cases for follow-up and partner services based on their sex, age, and the titer of their VDRL or RPR. So late syphilis or syphilis of unknown duration is defined as a person who has had no clinical symptoms or signs of primary or secondary syphilis who meets one of the following sets of criteria. So one, no prior history of syphilis or reactive serology. They have a history of syphilis and reactive serology that has increased, or they meet criteria for neurologic, ocular, otic, or later clinical manifestations. And tertiary syphilis is one of those later clinical manifestations, which is now, as I said, tertiary syphilis is now under the umbrella nomenclature of late syphilis. This occurs 10 to 30 years after an infection and develops in around a third of patients with unknown syphilis. It includes gammas and cardiovascular syphilis, including aortitis at the aortic root. Neurosyphilis is a separate entity. Tertiary syphilis is considered a non-infectious state. So for neurosyphilis, this can occur at any stage of the infection. In animal models, they've shown that the Treponema pallidum bacteria disseminates to the CNS within hours to days after inoculation. It should be noted, however, that neuroinvasion is not the same as neurosyphilis. If we just orienting yourself to this graph, on the left we have time. So time is moving from the superior aspect to the inferior aspect of the slide. And we can see that from the time of primary inoculation and the chancre formation, around 25 to 60% of individuals will have invasion of their central nervous system with the bacteria. That invasion can either lead to asymptomatic neuroinvasion, but 5% of people can actually develop symptomatic neurosyphilis, which includes meningitis, multiple cranial neuritis, ocular involvement, which is your can be visual disturbances or optic neuritis, and then meningococcal disease. So vasculitis involving, for instance, the cavernous sinus or the internal carotid artery can occur in these early syphilis cases. So around 4 to 10 weeks after that, we can get our secondary syphilis cases, which, as we just mentioned, can be early non-primary, non-secondary syphilis or late non-primary, non-secondary syphilis. And then around 20 to 30 years later, we end up with this tertiary syphilis that can include the cardiovascular syphilis in around 20 to 30, in around 10% of patients, and gummatous disease in 15%. And then tertiary syphilis in terms of neurosyphilis, this is the classic tabes dorsalis that we've all been taught in medical school, with a loss of vibration sense in the dorsal columns. And that occurs in 2 to 9% of people. And then general paresis occurs in 2 to 5% of people. So concrete estimates of the prevalence of neurosyphilis is lacking because there's no true gold standard. And consequently, what we've had to rely on is a combination of CSF findings and clinical findings. And sometimes we incorporate radiological findings to help us make the diagnosis as well. So according to the CDC, neurosyphilis can be defined as having a reactive non-treponemal test and a reactive treponemal test with both of the following: clinical symptoms of neurosyphilis, and as I mentioned, that can include meningitis, otic or optic neuritis, and a reactive VDRL in the CSF. Now, the sensitivity of the CSF VDRL is around 50 to 60%. So that is not that great. And you can imagine that we would miss cases if we were relying on the VDRL only. So because of that, they've also made this category likely neurosyphilis in case you have clinical symptoms, but you don't have that positive CSF VDRL. You can use some other surrogate markers such as the CSF protein if that's elevated, or the CSF white blood cell of greater than 5 white cells per millimeter. These can be just collaborative evidence that maybe the person has neurosyphilis. Some common questions are, can a diagnosis of neurosyphilis be made in the presence of a normal CSF examination? And this is just from the literature. Around 40% of persons with ocular syphilis will have a normal CSF. Similarly, over 90% of persons with otic syphilis will have normal CSF. So normal CSF can occur in those particular types of neurosyphilis. Who needs a lumbar puncture? So currently the CDC recommends that a CSF examination be performed in all persons with either serological evidence of syphilis and new onset neurological signs or symptoms, or if the person is asymptomatic with syphilis, but their serological titers have not declined by 4-fold following treatment for syphilis, appropriate treatment for syphilis. There's also a consideration for persons with HIV and syphilis if their VDRL or RPR titer is greater than 1 in 32, although I will say this is really falling out of favor in terms of performing an LP in the immunosuppressed HIV population. Ocular syphilis, this is some pictures over here. These are some of the pictures, how it can present. So clinicians should be aware of ocular syphilis and screen for it when persons have new onset visual complaints and they're at risk for syphilis. So particularly in the men who have sex with men population, persons who are HIV positive, or persons that have multiple partners, such as sex workers, then if they come in with new eye complaints, you should be thinking that syphilis may be contributing. If they have evidence of cranial nerve dysfunction, then a lumbar puncture is warranted. But congenital syphilis, this is caused by the infant or fetus getting syphilis in utero. It has a widespread spectrum of severity and manifestations, and the manifestations can be divided based on age. So for children less than 2 years old, they usually present with either jaundice or syphilitic rhinitis, known as snuffles. They can also have hepatosplenomegaly. For children greater than 2 years old, you look for the presence of Hutchinson's teeth, which is shown here as this little indent in most of your teeth. You can also have a saddle nose or Clutton's joints, as seen below. And as we mentioned before, because children are usually still, especially infants up to 6 months old, their antibodies are really reflecting their maternal antibodies. And so to diagnose it, you really have to use direct methods where you're actually looking for the syphilitic bacterium itself, either, as we said, with dark field microscopy or with PCR. But the antibodies will kind of misdiagnose because you may just be picking up maternal antibodies. And so in terms of the surge in congenital syphilis, how can we stop it? Now it's recommended that all pregnant women at their first prenatal visit be tested, and this is required in the US in 42 states. In Jamaica, they've also required that all women be tested in their first at their first prenatal visit, and we've also recently included that women should be retested in the third trimester, so around 28 weeks gestation. So all pregnant women should really have 2 tests during their pregnancy, one at the first antenatal visit and the other one in the third trimester. You should also test and treat the sex partner as well to avoid them getting reinfected during the pregnancy if they're positive. For pregnant women, only penicillin is approved for treatment. So HIV and syphilis co-infection, these have frequently been encountered together because they share similar modes of transmission, with either sexually or through bloodborne infections. So evidence also exists that the presence of one actually propels the acquisition of the other. So it makes it more vulnerable. It makes you more vulnerable to acquiring the other if you have one of them. So you should really screen all patients with HIV for syphilis and vice versa. There's a high risk of HIV positive sexually active groups that should be screened at least once a year. So it's not just ad hoc, but ongoing screening annually in certain high risk HIV positive populations, such as those who are sex workers or those who are men who have sex with men. In terms of the treatment, this is from the CDC. The treatment is dependent on the stage. So if we're talking about early syphilis, then you only need 1 dose of the 2.4 million units of benzathine penicillin intramuscularly. If it is late, or late non-primary, non-secondary syphilis, then we should do 3 doses for a total of 7.2 million units of benzathine penicillin. If you're pregnant, you follow the similar treatment depending on the stage, but it should be with benzathine penicillin. If you have neurosyphilis, this is the only time where they recommend using intravenous aqueous crystalline penicillin G, and that should be given for 10 to 14 days. So it's a daily infusion, most times it's a continuous infusion. And that includes ocular syphilis and otic syphilis. Any form of neurosyphilis, then they should be treated with aqueous crystalline penicillin G. With the penicillin shortage, the alternative treatment that people have recommended is doxycycline, 100 milligrams twice daily for 2 weeks for early syphilis, or for 4 weeks for late syphilis or syphilis of unknown duration. Doxycycline can also be used as an alternative in the non-pregnant population. However, if the person is pregnant, what they recommend is that you desensitize them in the ICU to penicillin so that they can get the proper treatment. So what is a cure? Once you've treated them, how do you define a cure? Cure is defined as a 4-fold drop in titer at 12 months after treatment of primary, secondary, and early latent syphilis, or a 4-fold drop at 24 months in late syphilis. Someone who is serofast is defined as having persistently low titers, around 35 to 44%. Retreatment in these serofast groups has not been shown to reduce titers or change their outcomes. So the prevention is the update in syphilis. So now the CDC has recommended doxycycline post-exposure prophylaxis for syphilis. And this is because 3 large clinical randomized trials had shown that doxycycline 100 milligrams twice a daily, or 200 milligrams taken within 72 hours after a sexual encounter or sexual exposure, has been shown to reduce the risk of syphilis and chlamydial infections by over 70%. It also reduces gonococcal infections by approximately 50%. But for the purposes of this talk, we are most concerned about that 70% reduction in cases of syphilis. So persons who are at risk should actually be treated. And I just had a case actually today referred to me of someone who had an exposure and was started on doxycycline 200 milligrams today. So we will see. Persons who are prescribed doxypep should undergo bacterial STI testing at other anatomic sites. So they should have pharyngeal, so that's like an oral or throat swab, as well as urethral if they're male, and anal swabs tested for all of these STIs. So that's chlamydia, gonorrhea. And then you should repeat this 3 to 6 months after starting doxypep. So the take-home points. 1, you should have a high index of suspicion for syphilis. We've seen that it is on the rise, continues to go up year over year. And it's called the great imitator because it can cause, weird rashes that are not necessarily involving the hands or palms. It can include eye symptoms. And you may think this is pink eye or red eye, but if the person has the correct risk factors, then you really should also be thinking about syphilis. Similarly, if persons, have alopecia and the correct risk factors, this is someone you may want to do a syphilis testing. You should be able to interpret the new testing algorithms because 1, you don't want to retreat people who have already been treated, and you don't want to miss people who are in the early stage. Penicillin is very expensive, and so you want to make sure you're treating the right stage. Increase screening in high-risk individuals, including babies born to mothers who are immunocompromised, pregnant women, men who have sex with men, individuals with HIV, and individuals who have substance use disorder. Don't forget to treat the partners. And also, don't forget we have a new weapon in our armamentarium of post-exposure prophylaxis with doxycycline that we can use to prevent these cases. Better ways to prevent it. We need renewed interest, funding in vaccinations, public education campaigns. We also need better ways to diagnose it, including possibly a PCR test that is widely available instead of relying on non-treponemal tests, which can be so difficult to interpret. We should have an expansion of joint HIV and syphilis testing. And wouldn't it be nice to have a rapid biofire which tests for all of the STIs altogether in one test through the urine, or something that's non-invasive? Thank you. And these are my references, and I will take some questions.
All right. Thank you so much, as usual, Dr. Pinckney. Well delivered. We enjoyed it, and we see a hand up already. Dr. Toms, you can go ahead with your question.
Thank you so much. And thank you, Dr. Pinckney. Really enjoyed your talk so far. I missed something. You had explained the difference between neurosyphilis and invasion of the sinus. I missed it. So I'm just asking for you to clarify that.
Sure.
And I also wanted you to comment on we're using a lot of things nowadays for prophylaxis, and in the face of increasing antibiotic resistance,
yeah,
I'm wondering if the emphasis should really be on prevention. But yeah, those are my 2 questions. Your thoughts on, okay, thank you.
So the first one in terms of neuroinvasion versus neurosyphilis, and I'll just go back to the slide, is that 25 to 60% of people will have neuroinvasion after their primary exposure with at the time of having the chancre. But just because you have neuroinvasion doesn't mean you have neurosyphilis. Neurosyphilis is defined by having some neurological symptoms. So whether that be an optic neuritis or a cranial nerve, a cranial neuritis, neuropathy, meningitis is another one, or the vasculature in the brain, so cavernous sinus thrombosis, cavernous sinus vasculitis, those intracranial signs of infection would be different from just the neuroinvasion, where the bacteria is present, but there are no neurological sequelae or symptoms that it has symptoms that it's causing.
And in that scenario, you don't treat. So if it's an incidental sign, but they have no symptoms, you don't treat.
Yeah. So I could imagine it being like someone that came in, well, I was going to say with Lyme disease, but maybe not in Jamaica. Someone that needed a lumbar puncture for something else, and they at the same time happen to have a positive enzyme immunoassay or troponemal test, then you would be questioning whether or not this is related to neuroinvasion or if it's related. But neuroinvasion, you should still be seeing some evidence of the bacteria, the treponemal bacteria in the CSF. Whereas if they're not infected. So in terms of doxycycline and antibiotic resistance, I think a lot of it has to do with risk benefit, and basically trying to determine from an epidemic standpoint what is the risk to your population. Like, you have to take it as a population glance. And with the rise, particularly in congenital syphilis and the severe morbidity mortality that's associated with it, there has been this need for joint or combined efforts. And I think if you were to weigh the cost of resistance to doxycycline versus the long-term effects of congenital or late-stage syphilis, that's where many of these like cost-effective analysis groups have come in and weighed that this is more cost-effective to use it as a post-exposure prophylaxis, because they have done cost-effective studies comparing what it would mean in terms of increase in treating doxycycline-resistant infections versus the reduced incidence of syphilis that you gain. And they have found it to be cost-effective. So I think it is a balancing act.
Okay, and I suppose time will tell, but between you and I think that when we introduced PrEP for HIV and post-exposure, maybe people relaxed a bit in terms of their condom use and safe sex practices, because syphilis was on the decrease before we had, prophylaxis.
Yes, I think for sure that, I mean, if we're talking about HIV pre-exposure and post-prophylaxis, that was in the beginning slides, one of the markers that increased the risk of, or the incidence of syphilis, because there was an increase in condomless sex with the introduction of HIV pre-exposure prophylaxis. But at the same time, there has been a marked decrease in HIV cases, right? With the latest one showing, I think, the injectable lenacapavir showing a 0% HIV infections in that HIV PrEP group. So once again, it's like, okay, now you're getting closer to eliminating HIV, which is associated with significant morbidity, mortality, and costs, versus treating syphilis, which is treatable, right? So I think it's
before now. Well, wait, I won't prolong it. I was just wondering if even now, in the face of prophylaxis for HIV, we should still be emphasizing safe sex and those kinds of messages, because it had worked before and has implications for the unknown. Maybe there is some other STI that may emerge, and monkeypox now is being linked to, sexual activity. So I just wondered if, the messaging,
I think the messaging can only go so far, which is why they came up with PrEP in the first place, because abstinence, condoms, etc. were being instituted, but there were still new cases of HIV. And so I think overall, we always have to be curious and looking for other methods. So I am still a proponent of a vaccine for syphilis, and as well as other methods of elimination for syphilis. But until then, I think you need as many tools in your toolbox to fight it as well. It's not that you should stop promoting safe sex practices, but you can promote it in tandem at the same time.
I think we agreed on that. Yeah, multiple. Yeah, thank you.
All right. I think I've lost faith in mankind to listen to good health education. But I see Dr. Jerome Walker has his hand up. You can go ahead, Dr. Walker.
Hi, afternoon, everyone. That was an excellent presentation, Dr. Pinckney, as expected and as usual. I really don't have really a question. It's really more of a comment. You had mentioned a few times that we were going to be starting using the CMIA in our lab. We have started, but it is with a caveat. A minority of laboratories in the United States use the method that we actually do, which is a selective methodology. So we will use the reverse algorithm in those cases where it's more obvious that it could be syphilis, and reserve the traditional algorithm for routine routine screens for syphilis.
I guess my question to you is, how have you found that it has increased the capacity, like the amount of tests that you're able to run, and reduce the manpower, or has it not made that much of an impact since it's not wide, broad scale yet?
So the one of, as you had said in the presentation, one of the benefits of the reverse algorithm is that it facilitates automation a little bit easier than using the traditional algorithm. And with automation, you can therefore process large numbers of samples. Right now, currently, the volume that the lab receives is such that it can be managed with the manual methods. So it's not really a huge advantage for us. If, however, we were to be suddenly overrun with hundreds of VDRLs per day, then it would be very difficult for that to be manageable using the traditional algorithm. So it is obviously one of the big reasons why, like in the United States, many of the laboratories are using the reverse algorithm. For us, it is for a number of reasons. The reality is the FDA ABS is labor intensive. It does require specialized expertise, and using the CMIA methodology kind of obviates that. I don't know if that answered your question.
Yes, it did. Thank you. Sorry, I was trying to find my mute button.
Okay,
still having Zoom issues 4 years later. I don't know.
Don't worry.
Will we ever get used to it?
Don't worry about it. It happens to all of us every now and again. All right. Are there any other questions? Or maybe I'll throw one in there. With regards to various labs, I don't know which other labs we may have online today in terms of their testing algorithms. Is there a magical cutoff number that you use for your non-treponemal VDRLs, RPRs to say, especially for like pregnant women who tend to have these false positives? What's that magic cutoff number to say, oh, this is likely not positive? I don't know who can answer that.
I don't have a magic cutoff number, like especially pregnant people. Yes, they can for the non-treponemal, because cardiolipin is one of those cross-reactive proteins. But because of the, I think the important implications of not treating them, I would definitely go on to at least take the whole clinical picture and make a very informed decision.
Right. So therefore, I also think that this is a part of or one of the factors that plays a role in them switching to the reverse testing algorithm, where you can knock out some of these false positives from early on and prevent persons to have to go through the process of being treated. I recently
Right.
a case like that. It was 1 in 4. Really didn't think it was positive. The confirmatory test was taking long to come, so mommy had to get some penicillin, and it came back
Yeah.
negative.
Yeah.
But,
I think it's always better to err on the side of
side of
caution and treat, because
yeah.
those congenital syphilis is kind of irreversible if they have especially neurological complications.
Exactly. And with the cases on the rise, we have to make sure. So, I mean, it's for each lab to basically look at their population, look at their numbers, the daily numbers that they're getting, and see how best, what suits you best to decrease your load and overall your, cost in the long run for the best outcomes. All right. If there are no more questions, we'll move on. If you're ready, Dr. Pinckney, to your next little talk.
Yes, I will say this talk is going to be very short because it's just on maternal RSV vaccines and the updates in that so far. So it's not as long as the other presentation. I'll start.
Exciting stuff, guys. These vaccines are out there, and yes, let's hear about it.
All right. Once again, are you guys seeing the screen okay?
Yes, we are.
All right, so maternal RSV vaccination. So I have no disclosures once again, and with this, we're gonna go through what is RSV, the epidemiology, and the new maternal RSV vaccines and why they're kind of important. So what is RSV? RSV is the human respiratory syncytial virus. It was first discovered in 1956 when a group of 14 chimpanzees were noted to be suffering from colds and coryza, which is runny nose. So it was actually originally named the chimpanzee coryza agent, or CCA, until Dr. Shancock, who is here on the left, and his co-workers confirmed that this same CCA virus was responsible for a respiratory illness in humans when they obtained isolates from 2 children. One child had laryngotracheal bronchitis and the other child had bronchopneumonia, but it was the same CCA virus. And so because of that, they actually did further studies and looked to find antibodies to this virus in school-age children. They had found that most children actually had these antibodies. And so the CCA, or the chimpanzee coryza agent virus, was appropriately renamed to the respiratory syncytial virus to denote its clinical and laboratory manifestations. So it is an enveloped, non-segmented, negative strand RNA virus. It is in the family Paramyxoviridae, in the subfamily Pneumovirinae. So there are 2 genera within the Pneumovirinae subfamily, and that's the metapneumovirus, which contains the human metapneumovirus, which is very popular, and then the pneumovirus, which contains the human RSV virus. In 1991, so around 30 years later, they were able to get more information about how RSV worked, how it replicated, because they were able to do a complete molecular cloning and sequencing of the RSV RNA to improve our understanding. And what they found was that the viral RNA consists of 15,222 nucleotides, which contains 10 genes. If you guys can see this at the bottom right-hand corner. Each gene encodes for a single protein except for the M2 gene, which actually codes for 2 different proteins. M21, which codes for a transcription processivity factor, and M22, which is a transcriptional regulatory protein. Then you have 4 other proteins that are associated with this internal RNA containing nucleocapsid. So the first one is the N, or nucleoprotein, the P, or phosphoprotein, which is this red protein right here, the L, or the large polymerase complex, and M2, which we had mentioned is a part of that transcription processivity factor. Then there are 3 transmembrane proteins, surface proteins that are associated with the envelope. First one is the F, or fusion protein, the G, which is the attachment protein, so that pink one, and then SH, which is the proposed viroporin protein, which is this yellow one. And so those are the 10 genes that code for the proteins in the RSV structure. So we should note that RSV is the leading cause of lower respiratory tract infections, including bronchiolitis and pneumonia, and it's the leading cause of hospitalizations in children younger than 2 years of age, and this is worldwide. Some risk factors for developing severe RSV in infants include premature birth, congenital heart disease, chronic lung disease, including asthma and cystic fibrosis, Down syndrome, people that are immunocompromised, and babies with severe neuromuscular diseases, for instance, muscular dystrophies. 79% of children hospitalized with RSV who are under 2 actually had no underlying medical conditions. So while these are conditions predispose you to getting RSV, they're not necessary for you to get it. And so you should keep it in mind if the person has respiratory symptoms. So in the US specifically, each year among children aged less than 5, RSV is associated with 100 to 300 deaths, 58,000 to 80,000 hospitalizations, 520,000 emergency department visits, and 1,500,000 outpatient visits. So high disease burden there. It typically causes seasonal outbreaks throughout the world. So in the Northern Hemisphere, like the United States, it usually occurs between October and November to April, with a peak in January or February. While in the tropical regions and semi-tropical climates, the seasonal outbreaks usually occur in the rainy season. And in Jamaica, for instance, I remember this is November 2022, Minister Tufton was postulating whether RSV was driving the increased hospital admissions, particularly at Bustamante Children's Hospital. And so they were actually sending samples over to Trinidad to get tested for RSV. At that time, there was over a 400% increase in severe acute respiratory infections over a 4-week period. And so with that burden and the fact that children who are so vulnerable are being impacted, came this study, which is the basis of today's talk, the bivalent prefusion F vaccine in pregnancy to prevent RSV illness in infants. It's led by the Matisse study group, first author Kampman. And just to go over what the prefusion form of the RSV protein is, it is the major target of potent virus neutralizing antibodies that we produce. And I don't know if you guys are seeing this properly, but here is the RSV prefusion protein. You can see it's kind of opened up like a flower. And with that, it's exposing more and more proteins, or larger surface area of proteins for your body to generate neutralizing antibodies to. And so you get a higher level of antibodies being formed if you have it in the prefusion state versus in the post-fusion state, where it's kind of closed up, and so not that many proteins are exposed. And this is actually, this prefusion protein is actually what they mimicked to do the spike protein, because spike protein for COVID vaccines, similarly, they made it in the prefusion form to allow maximum generation of neutralizing antibodies. So the investigational bivalent RSV prefusion vaccine contains stabilized prefusion glycoproteins from 2 main co-circulating antigenic subgroups of RSV-A and RSV-B. In phase 2B proof of concept trials, the RSV prefusion vaccine, when administered to women in the late 2nd or early 3rd trimester of pregnancy, it had not only a adequate safety profile, but a great neutralizing antibody response. And these antibodies were successfully transferred via the placenta to the fetal cells. And these antibodies were able to provide protection in the infants against RSV immediately after birth and during the first few months of life. So for this study, missing a slide, but essentially it was a randomized clinical trial that had 18 countries. You had 3,495 pregnant women randomized to getting the prefusion vaccine and 3,480 randomized to getting a placebo. And what they were able to show, as you can see in this one, if you look at the y-axis, is the number of days after birth. And sorry, the x-axis is the number of days after birth, and the y-axis is the incidence of RSV. We can see that 90 days after birth, there were just 6 cases of RSV severe infection in the vaccinated group compared to 33 cases in the placebo group. And that was equivalent to an 81% reduction in infections or 81% vaccine efficacy after 90 days. And that's this very big gap that you can see between the placebo group and the RSV vaccine group. This waned over time, as most neutralizing antibodies do. So by the 180th day, it was not that big of a difference between the treated and the untreated arm. So it was 19 cases in the vaccinated arm versus 62 in the placebo arm, leading to a 69% reduction. But this is still, in the broad scheme of things, a very huge reduction in the number of severe RSV, lower respiratory tract infections in infants. Similarly, if we are just talking about medically attended, so this is not severe RSV in the ICU, this is just people that are missing school because of bronchiolitis and wheezing or attending an outpatient, their pediatrician visit, etc. So within 90 days, once again, those in the treated or vaccinated group, there were 24 cases compared to 56 cases in the placebo group. That was equivalent to a 57.1% reduction in medically attended RSV, lower respiratory tract illness. And this, once again, waned over time, where by 180 days after birth, it was just a 51% reduction in the RSV, medically attended RSV LRTIs. So because of this wonderful study, and everyone was very excited about these results and the reduction in RSV, the maternal RSV vaccine that is approved is Abruzzo, and this is by Pfizer. And just to note that this is different from GSK's RSV vaccine, which is not approved for pregnant people because of an increased risk in preterm births. So the one that's approved is Pfizer's Abruzzo, and that was approved on August 21st last year. It's approved as a single dose to be given at 32 through 36 weeks gestation. Even though in the actual study, that Matisse study that we just went through, it was given during 24 to 36 weeks gestation. They found that the level of antibody titers were highest in the infants if it was given after the 32 weeks. And so they decided to use that as a cutoff. They also found that there was less association with preterm deliveries if it was given after 32 weeks. Okay, I think this is where the other study was. So how has the maternal RSV vaccine uptake been since it has been released? This is data from the CDC. They call it the Vaccine Safety Data Link, or VSD, which collects data from around 18 different hospital systems in the US that deliver infants. And you can see that the uptake was really low. So overall, this is disaggregated by race, where the bottom green line is the Black population, Black pregnant population, and the upmost red line here is the Asian population. If we look overall, or the overall group is in this orange color here. So we can see that the percentage vaccinated from September to January of last year was overall around 15 to 16%, with the Black pregnant population having the lowest uptake of around 10%, and the Asian population having the highest uptake of around 25%, which is still low. There are multiple reasons why vaccine uptake was low. Obviously, it's a new vaccine. The rollout was not as smooth, particularly in terms of getting it covered by the insurance. Pregnant women were not as familiar with it as other vaccines, including tetanus, which is recommended during pregnancy, or the flu. So in terms of trust in the vaccine, it was lower than trust in, for instance, the tetanus vaccine, which has been around for a much longer time. And so I think that contributed to the uptake being that low. In terms of the uptake in the Caribbean, we don't really, it was not put on our maternal registry, immunization registry, even though we know, as we saw with the COVID vaccine, there are people that leave Jamaica or other parts of the Caribbean and get vaccinated in another country and then come back. So there may have been some of these pregnant people that were vaccinated against RSV that we were not aware of. And one of the reasons we're not aware is because we don't have a maternal immunization registry. And so this is kind of more so a plug for the Caribbean to get a maternal immunization registry. We have a immunization advisory group called the Caribbean Immunization Technical Advisory Group, or CITAG, which is supposed to be helpful in terms of coordination of getting an electronic immunization registry that is coordinated among different parts of the Caribbean, but that has not yet been borne out in terms of the maternal population. So if there are any young people on the call that are into technology, I think this is a great project that they should take on to really monitor and track not only just RSV vaccines, but or tetanus vaccines, COVID and flu vaccines that are recommended for pregnant people, and monitoring how their trust in that vaccine and the uptake of that vaccine, which can have real implications in reducing the number of RSV-related hospitalizations among infants. And not just hospitalizations, but RSV has also been attributed to bronchiolitis and wheezing and increased incidence of asthma, for instance. And so by immunizing this population against it, we can hopefully reduce the incidence of those chronic illnesses as well. And these are my references, and I will take questions.
All right, thanks again. And Dr. Toms is first on the draw again, followed by Dr. Walker. Okay, go ahead.
I'm juggling, doctor. So could you just give me some, you said that the vaccine is to be given in pregnancy. I missed why. Why pregnancy and not at birth? And I know you said the Pfizer was the one approved because that one can be given in pregnancy. Do you know when the GSK vaccine should be given? Any important side effects that we need to be looking for? Forgive me if you said it and I missed it. And how many doses? Sorry, I was joking.
Okay, so yeah, so the one that is approved for pregnancy is Abrysvo. There is a alternative to giving it to pregnant people, but the I guess the model that they were trying to emulate with this was that used for tetanus vaccines, which, as you know, has been given for many years in pregnant people to increase the antibodies that would be present at birth and prevent infections, neonatal tetanus infections, particularly in that 0 to 6 month age group, were then able to mount their own response. And so it's a faster way of getting some immune protection to the infant than giving the infants their own immunization. But there is a agent that they're using for the neonates as well called nirsevimab. And so pregnant people do have the option whether they want to get the vaccine during pregnancy or give that birth dose of nirsevimab, I think that's how you pronounce it, to the infants. So they have a choice. In terms of the reason Abrysvio is approved and the GSK vaccine is not approved for pregnant women is because the GSK vaccine was associated with an increased risk of preterm birth in pregnant people, more so than the placebo group. And so it's not advised that that be given during pregnancy because of that safety marker. In terms of side effects, like all vaccines, is the risk of fever, arm pain, muscle pain, flu-like illness, etc. The most serious side effect that people worry about is preterm birth. And again, similar to the GSK vaccine, while it wasn't increasing preterm births, they did change the labeling from 24 to 36 weeks, which is what they used in the Matisse study, and only approved it for 32 to 36 weeks, because that 24 to 32 week period was associated with increased preterm delivery if you gave it during that time when they disaggregated the data. And so that's one of the main things. But there is no increased risk of, for instance, congenital birth defects or other life-threatening illnesses with the vaccine compared to people in the placebo group. Sorry, I know you had one more question. I don't remember what it was.
I think the answer was it had said. So it's just a one dose during that period.
Yes, it's a one-time dose, yes, during the 32 to 36 weeks.
All right. Thank you so much. Congratulations again. All right.
All right, Dr. Walker.
Hi again, everybody. Yes, excellent presentation once again. It's more of a comment, but it's very good, to hear a good talk about RSV. I think one of the reasons that we haven't put these vaccines, on our formulary is that there's a lack of data. What really is happening here locally. The good thing is that Josh Danziger through the APDC's Abbott Pandemic Coalition has secured antigen testing for RSV, and so that has begun on a screening of all of our respiratory patients that are coming in through A&E, and also further through Dr. Michelle Brown, the National Influenza Center, PAHO, Ministry of Health, that they also go on to do PCR testing, not only for COVID and influenza A and B, but also for RSV. So if going through these patients, notes is very pleasing to see, this fairly comprehensive panel of both antigen and PCR testing being done. So, it's not really that time of year. I don't recall seeing any positive RSVs. It's been a few months now, maybe 3 months or so. But, maybe in months coming, we have all of these climate change events happening and lots more rain. So who knows? So we might have some data and be able to show, the need. So I really appreciated this presentation, and talking, it was fairly comprehensive. I thought it was really good, talking about nirsevimab, all of those things, really great. Thanks, Dr. Pinkney again.
Thank you so much, Joe. I had a question for you, and I'm not sure if you guys would have this answer, but that news clip that I showed with Minister Tufton, stating that those samples were being sent over to Trinidad for testing to, I guess, CARPO. Do you know if those results had come back and if it really was being that 400% increase in cases was being driven by RSV, or we didn't really get the answer?
I couldn't tell you. I didn't hear anything either way, neither through the media or anything. I could look back at some of the epi reports that are available on the ministry's website, but I don't recall seeing anything being reported through that format. I've checked in a few weeks, but up
Yeah,
until a few weeks ago, I hadn't seen any reports in that
yeah.
format. Like,
Thank you. Yeah, I hadn't seen it either. I was just wondering if there was some inside information. But yeah, I think, yeah, Dr. Ansinger, that's great. You know, because we, as you said, we need at least the baseline epi data to know what our burden is. It may not be the same as other places, but it would be interesting to have a definitive answer for why we're seeing these surges, as you said, in the specific time of year, particularly November, December, in hospitalizations at Busto or other children's hospitals. And if it is RSV, now we have a tool that we can use to protect those babies.
fully agree.
All right. Do we have any more questions? Anybody else has any other questions they want to ask as it relates to this topic? Or, you know, her brain is here for the picking. If you have anything else you'd want to find out about, feel free to ask now. And in the meantime, I want to say thank you again, Dr. Pinkney. You're always ready and willing and able, and we always know that we're in for a treat whenever you're on. I see a hand. Oh, it's a clap. Yay.
Oh, thank you.
Thank you. Thank you again, and looking forward to seeing you again next year. All right.
Thank you so much for inviting me. It's always a pleasure. And yeah, I'm always happy to be back. Thank you so much.
Not a problem. Thank you again. And to everyone who is online today, I want to say thank you for tuning in. Thank you for being a great audience. And we hope to see you again next year. Hopefully, we'll have more days. Last year, we had about 5 weeks worth of summer school, but this year we only had 2. But looking forward to next year, we have a lot of young microbiologists online. We're going to pick on them as well to deliver some of the lectures during our summer school series. And just want to say thank you to everyone. Have a great evening and see you soon. Bye.
Thank you.
Thank you. Take care, everyone.
That's
Thank you.